Hello, I'm Nick Webb, the editor-in-chief of APOS Trends in Orthodontics. My editorial tenure commenced in 2010 and ends at the end of this APOC. Professor Eric Liu from the Taiwan Association of Orthodontists will be the new editor-in-chief of APOS Trends in Orthodontics after this meeting. The agenda for this presentation is to tell you about the APOS trends journey over the last decade. And in case you'd like to submit to our journal, give you some information about submission of manuscripts, as well as some basic metrics about the journal. This particular journal has actually been the brainchild of Dr. Lo Kai Vo, whom you see at the center of your screen. He was the APOS president from 2010 to 2012. At the 7th IOC, which also jointly hosted the APOC, that is like in 2020, where Yokohama was supposed to host both the International Orthodontic Congress and the Asian Pacific Orthodontic Conference. I attended this event. This event was quite a spectacular show. On my way back from Sydney, Australia, I had a brief stopover in Singapore where Dr. Loh invited me to lunch and treated me to what I categorically remember was some of the best egg tarts I've ever had. The discussion focused on his vision for the Asian Pacific Orthodontic Society and the idea of starting a newsletter as well as a journal germinated. He asked me to spearhead the project, and before we knew, APOS Trends in Orthodontics was a reality. Its website, www.apospublications.com, has remained unchanged since. The first few years of the journal were humble beginnings without a publishing house. Incidentally, this journal is still self-funded. Neither are readers asked to pay a fee to download any article. Everything is open access, nor are authors asked for a submission fee. The journal also does not tax the financial resources of the Asian Pacific Orthodontic Society and only survives on generous contributions from industry partners, to whom we are thankful. This is how the first few issues look like. 2013 was an important landmark when we partnered with a professional publishing house that is Wolters Kluwer's. And since then, the journal has been published and has been getting citations. Every article had a DOI that was generated. The journal has grown from strength to strength. In 2018, we changed our publishers to Scientific Scholar, who are our current publishers and host the side of the journal. This is essentially an electronic journal which is published quarterly. It can also be printed on demand. Currently, it's the 10th volume of the journal that is online. Every single year is a new volume, and every issue has a separate number. All the archives can be found on the website. We receive around 200 submissions a year, and this number has been growing slowly but steadily over the years. Our acceptance rates are currently at around 30% and should see another 10% drop over the next few years. That means that out of 10 papers submitted to us, only 2 are likely to be accepted after a very, very rigorous peer review process. Around 200,000 times are our papers downloaded in a single calendar year. And that number is only growing. At a given time, we have 30,000 readers around the world. Our reader demographics is people from all around the world who are online on the journal site at any point in time. And more than 75% of those people, that's what the bounce rate is. They come back to the site. What kind of papers are we publishing? Every issue has an editorial. We do have some reviews, but we encourage systematic and scoping reviews. Narrative reviews are low on our priority list. Since 2017, we've been inviting global experts to contribute an experts corner, which essentially is their perspective or a summation of literature on a given topic. These expert corners have become very popular. They've been featured on popular orthodontic websites, as well as are a part of many teaching curriculums around the world. Amongst the articles that are non-invitational, what we are essentially looking at are three kinds of submissions. Original articles, which is original research of the highest quality. It could be clinical or laboratory research, but primary research. We're looking at clinical articles, which are case reports. A small proportion of them are published in our journal. They've got to be high quality case reports with records and something that add to orthodontic literature. We do also accept techniques and clinical pearls, probably for a year get published. We're looking at these kind of papers to have good quality of photographs, as well as the photographs should be self-explanatory. This is the website that houses the journal. If you browse through the website, you will get icons on the top. The first one directs you to the society website, which is the Asian Pacific Orthodontic Society site, and that is APOS Ortho. That is the site of the society, which I'm sorry, I got that wrong, was Asian Pacific Ortho.org. This does not direct you to the journal site. The issues section, if you were to click on this, you will be taken to all the archives. The editorial board section tells you information about the editorial board. Now, what should interest you is this particular section, which is for authors. This section directs you to the submission page with explicit instructions, as well as a video tutorial. And you may also contact the publishing house or the editorial office for further details. Remember, the journal website is www.apospublications.com. What are we essentially looking for? Manuscripts that can be cited in orthodontic literature to improve the journal's impact factor. So essentially, we're looking at citable manuscripts, something that adds to the pre-existing orthodontic knowledge base. Very often, we've got to reject some very excellently researched as well as written papers if they do not add anything to the orthodontic knowledge base. We're looking at evidence-based information, something that is not opinionated, and finally, good and ethical science. Ethics of publication is something that is of paramount importance to the APOS trends in orthodontics. Some manuscripts that meet all these criteria are awarded every 2 years, and you will be hearing from the winners of the 2020 APOS Trends Awards after this presentation. We encourage you to publish because we've all taken from the table of published orthodontic literature. It's our responsibility to give back. Thank you so much for a patient hearing. Hello. It's now time to announce the APOS Trends Awards for the year 2020. But before I announce these awards, it's important to know the 5 gentlemen who are honored by having these awards named after them by the Asian Pacific Orthodontic Society. Dr. Fu Min Kui represented the Chinese Orthodontic Society. Dr. Renato Africa represented the Association of Philippine Orthodontists. Dr. Jyotindra Kumar represented the Indian Orthodontic Society. Dr. Henry Kusnoto represented the Indonesian Association of Orthodontists, and Dr. Lo Su An represented the Association of Orthodontists Singapore at the time of the signing of the APOS Charter. The winners of the 2020 APOS Trends Award are Doctors Sang Sang, Franklin Shi, Anita Tak Ying Yong, who have won the Fu Min Kui APOS Trends Award for the Best Clinical Article for their paper on interdisciplinary management of an orthodontic patient with temporomandibular disorder. The winners of the Renato Africa APOS Trends Award for the second best clinical article are Dr. Marcio Rodriguez Almeida, Dr. Renato Rodriguez Almeida, and Dr. Ravindra Nanda for their paper titled Biomechanics of Extraalveolar Mini Implant Use in the Infrazygomatic Crest Area for Asymmetrical Correction of Class 2 Subdivision Malocclusion. The Jyotindra Kumar APOS Trends Award for the Best Original Research are Dr. Peter Ngan, Dr. Owen Kelly Nguyen, Dr. Tung Nguyen, Dr. Timothy Tremont, Dr. Chris Martin for their paper titled Skeletal Dentoalveolar and Periodontal Changes of Skeletally Matured Patients with Maxillary Deficiency Treated with Microimplant Assisted Rapid Palatal Expansion, a pilot study. The Henry Kusnoto APOS Trends Award for the second best original research article goes to Doctors Hayashi, Fujita, Sukuka, Tane, and Tanimoto from the Hiroshima University, Japan, for their paper titled Role of Articular Disc in Cartilaginous Growth of Mandible in Rats. The Lu Su An Award, the Best Clinical Innovation Pearl Article, and there is only one award awarded in this category, goes to Doctors Paul, Lijil, Beneath, and Biswas from India for a modified lingual bonding technique. At this time, it's also important that we announce the Editorial Board's Choice Award for the best reviewers who selflessly worked very hard to improve the quality of this journal. The winners of these awards are Dr. Sridevi Padmanabhan from India and Dr. Letizia Perillo from Italy. The jury for the Best Paper Awards was Dr. Keiji Moriyama, Rabindra Manshrestha, and Tanan Jaruprakon. The editorial board thanks them for meticulously scoring the various manuscripts and selecting the winners. Thank you for watching APOS Trends Award 2020. Until we meet each other again at the next APOC in Seoul, that is going to be hosted by the Korean Association of Orthodontists. This is Nick Vaid, the EIC, signing off.
Hello, I'm Peter Ngan. Thank you for attending the IOC meeting. I was asked to present a paper published in the APOS Trends Orthodontic Journal back in 2018. Maxillary transverse deficiency, or MTD, is characterized by a constricted maxilla relative to the surrounding craniofacial structures. It is usually manifest as a unilateral or bilateral posterior crossbite with dental crowding or even protrusion of anterior teeth. It is actually quite a prevalence malocclusion, about 8 to 23% in children, and also about 30% of the adult population. This malocclusion is usually treated by maxillary palatal expansion, or RPE. It has a jack screws and is kind of reinforced by orthodontic bands or acrylic. And it widens the maxilla by disrupting the circummaxillary sutural system. The effect of maxillary expansion involved both skeletal expansion, or the mid-palatal suture separation, or alveolar bone bending and dental tipping. So Dr. Beard Melson already shown that the maturation of sutures change with age, and there is progressive articulation of the maxillary sutures, so it's harder and harder to separate with just orthodontic or dental anchorage. So in adult patient, the most difficult part to separate is, or you get most resistance to expansion in the zygomatic buttress area, in the piriform aperture area, and also at the back will be the pterygoid junction area. So in adult patient, it will be recommended to use the surgical assisted rapid palatal expansion, which is called SAPI. So the results are a bit more predictable and also more parallel expansion that might be also good with airway and less relapse. So a group of Korean Southeast Asian investigators came up with a device called MARPE appliance, for treating young adults, because there are patients that could not afford surgical treatment. Is too invasive, and also they may not have insurance. So in younger patients, you might be able to use rapid palatal expansion appliance that are anchored with 4 microimplants. So this study, what its aim is to find out the skeletal, dental, and also periodontal changes with this new appliance called MARPE. So we obtained IRB from our university to conduct this study. We look at about 15 patients that are consecutively treated by this MARPE appliance. The inclusion criteria, so these patients must be relatively skeletally mature, CBM greater than 4. So we wind up with a group that is about 21 and 22 years old, and we look at the expansion after about 7 or 8 weeks. We look at several variables: skeletal, dental, alveolar, and also periodontal variables such as buccal bone thickness. So all the CBCT scans were oriented in 3 planes of space, and we used the software Anatomarch or InVivo5 to look at the measurements. So first, we look at the mid-palatal sutural separation. We look at both at the axial and coronal planes. So we found out that 100% of our patients have mid-palatal sutural separation, and they are actually quite parallel in both the axial and coronal planes. So if you compare to a bigger study by Choi et al., which looked at about 69 patients, and they found that about 67% success rate. So there are patients who are too skeletally mature that you don't get skeletal expansion. So in the coronal view, that means if you look at the patients from the front to the back, And we found out that, there are some patients with triangular separation. And that's also shown in the literature also. And this might have something to do with the activation rate and things like that. On the axial view, we also found out that our study, we have a little bit more parallel expansion from the front to the back. But in other studies, they found out that, it's usually a little bit more triangular like the conventional expansion appliance. Now that might have to do with where you place the jack screw, whether more in the front or more at the back because of the pterygomaxillary buttress bone in the back. Now we also look at the upper facial bone, which is the zygomatic buttress area and also the infrazygomatic area. So we asked Dr. Wynn, who's kind enough, to do the color mapping for us. As you can see, the area that are a little bit more darker red color, the one that have more skeletal change. The one in the zygomatical area, you have less or more yellow or orange color, which have less change. So it is still a triangular type of changes. And we have found out that, positive color change were observed in both of these areas. So that means that, not only the separation is triangular, we also found out that, patients that are over 30 years old can still, the sutures may still be patent and you can still get separation. Now, the other thing we look at is obviously alveolar bone bending and also dental tipping. So both of them are significant. So that means that even though with the additional anchorage provided by the mini implants, you still have side effects of alveolar bone bending and dental tipping. So we found out that the percentage attributed, to these three areas is 41% skeletal, 12% alveolar bone bending, and 47% dental tipping. What about the periodontal changes? Well, we found out that, yes, if you have dental side effect, you also have less or decrease in bone thickness in the buccal area of the anchor teeth. So we make a summary that mid-palatal suture separations can be obtained in 100% if you pick the patient correctly. That means that they are not too skeletal mature, but these are young adult patients. And the percentage of skeletal and dental contribution is about 41% skeletal, 12% then alveolar bone bending, and 48% dental tipping. The pattern of separation is more parallel if you have the 4 mini screws as additional anchorage. So we still find dental tipping with that. There is also reduction in buccal bone thickness, which is a side effects of these appliances. So we conclude that the MARPE appliance can be clinically acceptable as a non-surgical treatment for young adults. So these are mild to moderate maxillary transverse discrepancy less than 7 millimeters, and hopefully clinicians can use this appliance down the road for patients in the early permanent dentition. Thank you very much for your kind attention.
It's a great honor for me to be here to present our research nominated as Hendrix Note APOS Trends Orthod. Title of the presentation is Role of articular disc in cartilaginous growth of the mandible in rats. This slide shows the self-introduction of the presenter. To the best of our knowledge, the named authors have no conflict of interest, financial or otherwise, related to the presentation at the 9th IOC in Yokohama. In daily orthodontic practice, we occasionally experience maxillary protrusion and open bite with distally positioned and rest-developed mandible due to internal derangement of the TMJ osteoarthritis in particular. And this slide shows an example of such patient. This transformed patient underwent orthodontic treatment from 11 to 14-year-old. However, after retention, she exhibited maxillary protrusion and open bite with distally located and rest-developed mandible. In addition, her interarticular pathology was diagnosed as TMJ internal derangement with anterior disc displacement with a reduction and progressive condyle resorption. It is speculated that anterior disc displacement with a reduction may affect mandibular growth. Thus, this study was designed to examine if mandibular growth is affected by discectomy, simulating disc displacement in growing rats. 18 Western male rats were divided equally into two groups. Two group rats underwent TMJ discectomy and sham operation, which are called as discectomy and control groups, respectively. At age 4 weeks, bilateral discectomy was performed in the discectomy group. 4 weeks after initiating experiment, lateral cephalograms were taken over all rats, and landmarks and measurement items were established as shown here. For the morphometric measurement of the condyle, micro-CT examination was performed for the condyle at 4 weeks after initiating the experiment. The length, width, and thickness of the condyle were measured on each CT image. The change in the size of the condyle were determined by calculating the absolute difference in the measured values before and after discectomy. 4 weeks after the beginning of the experiment, both TMJ were dissected out and a specimen of 7 micrometer thickness stained with hematoxylin and eosin was subjected to histomorphometric analysis. The thickness of 4 cartilage layers was quantified using a computer-assisted image analyzing system, and then compared between the discectomy and control groups. In the discectomy group, menton to condyle, menton to UN, and menton to LN was significantly smaller than in the control. On the other hand, menton to LI was significantly greater in the discectomy group than in the control groups. In addition, morphological differences were found prominently on superimposed cephalomeric superimpositions between the discectomy and control groups. The condyles of the experimental group exhibited morphological changes on CT image on day 29. The most remarkable difference was observed on the shape of condyle. In other words, the condyles became flattened in the dissecting group than in the control. A significant difference in the length of condyle was also observed between two groups on day 28. This slide shows sections of rat condyle. In controls, the condyle exhibited a round and smooth articular surface without any pathological sign. For different layers of the cartilage were clearly distinguished, and cells were arranged regularly. On the other hand, the condyle became flattened in the dissecting group than in the control. The surface of condyle was rougher in the dissecting group than in the controls. The thickness of condyle cartilage layers became smaller when compared to the controls. Although 4 cartilage layers were detected in the dissectomy group, the boundary zone between layers was unclear. Furthermore, the fibrous and lower hypertrophic layers were significantly thicker and thinner than in the control, respectively. In conclusion, bilateral tumor discectomy in growing rats caused significant reductions in mandibular growth. A defect in the articular disc affected mandibular growth substantially, suggesting that the articular disc is crucial in mandibular cartilaginous growth. It is thus demonstrated that intra-articular pathology associated with disc displacement affects growth and development of the mandible and the subsequent outcome of orthodontic treatment. And thus, it is hopefully anticipated from the present study that TMJ disorders, TMJ internal derangement in particular, are to be prevented or cured when the intra-articular pathology is in the early stage with reducible anterior disc displacement, which can be cured with a series of conservative treatment with spin therapy and the following occlusal reconstruction. Thank you very much for your kind attention.
Hi everyone, this is Franklin Shi from Hong Kong, China. I'm going to present a case which was published in APOS Trends in Orthodontics with Dr. Anita Wong, specialist in postodontics. Eugenia was 22 years old. She had mild maxillary protrusion, which I wanted to improve. Also, I wanted to upright her retroclide upper incisors. We have to accept her slightly long upper lip and her deviated chin. I aim to improve her rest incisor exposure from 5 to 2 mm. She had 2 mm gingival exposure at post-smile, which was normal. I plan to reduce her lip separation and had to accept her convex lateral profile and retrusive mandible. The pretreatment lateral step showed clearly the retroclide upper incisors that I plan to improve. I plan also to level the upper occlusal plane as it appears to be too steep. Missing 1/8, 2/8, 3/8, and impacted 4/8. She also had condyle resorption of the left, which could explain the chin deviation. I plan to relieve the crowding of the upper and lower arches and correct distal lingual rotated 4/6. I also plan to open up space for building up the patch shape 1, 2, and 2, 2, correct the lower midline shift to left, and upright the retroclide upper and lower incisors. In addition, I plan to correct the asymmetric molar relationship, which was small class 2 on the left, and asymmetric extraction was an option. A typical plan to address the problem is asymmetric extraction of only 4/5 on the lower arch while extracting 1/4 and 2/4 on the upper arch. Since Eugenia complained of joint pain, I refer her to Anita for spin therapy before starting ortho. The treatment relieved pain and improved function. However, it also changed her occlusion. Before spin therapy at CO, there were multiple interocclusal contacts. After the spin therapy, there was a reproducible CR which only 1/7 to 4/7, 2/4 to 3/3 were contacting each other. The spin therapy increased the overjet and accentuated the incomplete overbite. Most importantly, it changed the molar relationship on the right from half units to full unit class 2, which tell us that we should not extract 4/5. Otherwise, we will need to bring 4/6 forward 7 mm into class 1, which is almost impossible even with minuscule anchorage. I superimposed the digital model after the spin therapy to the lateral shaft and rotate the lower model in a counterclockwise direction with 2 mm overlap of upper and lower 5 molars. It simulated the effects of molar intrusion by minuscule anchorage. It will bring the lower model forward slightly and hence will affect the anchorage demand. I plan to intrude the upper incisors 3 mm, procline them 1 mm and upright the teeth 10 degrees in a counterclockwise direction to put their roots in the middle of the bone and reduce rest incisor exposure from 5 to 2 mm. As the mandible rotates counterclockwise in response to 2 mm of molar intrusion, incomplete overbite improves, and the lower incisors then have to be protracted 3 mm to attain the inter-incisal contact. An occlusogram was constructed based on the counterclockwise rotation of the manifold, which indicated moderate to maximum anchorage requirement. To achieve the objectives, I have applied a 5 mini-screw setup with the support of a modified TPA on the upper arch. It allowed the application of individual intrusion forces, which are applied based on the clinical response so that occlusal plane will rotate in the counterclockwise direction as planned, with the front teeth intruding more than the back teeth. At the same time, I can add power chain to retract the upper incisors and partially close the extraction space. The manifold will rotate in the counterclockwise direction as planned. The residual space will be closed by reciprocal anchorage, allowing the molars to move forward. This will result in moderate to maximum anchorage, which was planned initially. On the lower arch at quadrant 3, the lower left first molar has to move forward 2 mm, while at the quadrant 4, the lower right first molar has to retract 1.5 mm. By doing that, the asymmetric molar relationship can be normalized. On the left side, I plan to use a beta titanium loop to bring the molars towards the mini-screw, which was placed between 6 and 7. The passive form of the projection loop is shown by the dotted line. On the right, I plan to retract the teeth towards the mini-screw installed between 4.5 and 4.6. Therefore, 4.8 was extracted surgically. This is the rotator 4.6. It was aligned nicely and stabilized by a lingual arch. At the same time, we have started to intrude and retract the upper dentition and correct the lower midline. A torquing spring was installed. It is basically a snap-on cantilever which produced a counterclockwise movement to upright the upper incisors. I'm still intruding and retracting the upper teeth. The lower midline shift was corrected and retrocide upper incisors were improved. As the treatment proceeds, we can see that new bone had formed distal to 3.6 after 6 months of mesialization. On the upper occlusal view, we can see a modified TPA with hooks at 1.5 and 2.5 region. The TPA controlled the arch width during molar intrusion, and the hooks help intruding the palatal cuts of 1.5 and 2.5. You can see that I was retracting upper canine separately to open space distal to laterals for future restoration. This is the end of the orthodontic treatment. Composite build-up were done on the lateral incisors, post-treatment lateral ceph and tracing, Saphometric superimposition on tracings immediately after mini-screw placement, which is in blue, and after orthodontics, which is in red. Before and after treatment, rest incisor exposure was reduced from 5 to 2 mm. The smile arc was consonant. Lip separation was reduced. Her maxillary protrusion was improved. Post-treatment panoramic radiograph, we can see that there were some root resorption of her upper incisors. Before orthodontic treatment and after composite build-ups, midline was corrected. The lower arch became symmetrical. The upper arch was shortened due to extraction. Suck-in buccal occlusion on the right. Suck-in buccal occlusion also on the left side. Treatment time was 3 years. Thank you very much for your attention.
Hi, my name is Marcio Almeida. I'm from Brazil. It's a great pleasure and also a great honor to be speaking at this virtual meeting at the International Orthodontic Congress. I'd like to take this opportunity to thank my co-authors, which is my father, Renato Almeida, and my biomechanics father, Dr. Ravi Nanda. So our paper received the APOS award as the second best clinical article. And I'm gonna show you how we can easily correct an asymmetrical malocclusion. Over the last decade, we have seen a revolution in the way we have been using mini screws, allocated primarily in the interradicular area, that is, between the roots. However, the astroalveolar mini screws inserted in the infrazygomatic crest and also at the buccal shelf area appeared, allowing free dental movement along the maxillary and dental arches. Since the screws are placed outside the roots, you might get also a better stability compared to mini screws inserted between the roots. Some asymmetrical cases can be easily treated by using astroalveolar mini screws. So this is our patient, an adult patient. We can see an asymmetry in the maxillary arch. It seems an arch rotation, which is called EO. She had a full class 2 on the right side and a class 1 on the left. Her up midline is shifted to the left 3.5 millimeters. She also has a convex profile and also a consonant smile arc. Let me show you the occlusal view. It's easy to see from this perspective that she has an arch rotation, an asymmetry. So my question is, what would be our best treatment planning? My treatment planning was to extract maxillary third molar and to distalize the dentition on the right side. So we start leveling and aligning with 014 copper nightie arch wires, followed by 14 by 25 copper nightie. You can see here the asymmetry on the maxillary midline, and we are gonna start to use the infrazygomatic crest screw in this phase. Now, let me tell you why the knowledge of biomechanics is so important when we are dealing with asymmetrical mechanics and mini screws. Take a look here. The screw was inserted far away from the arch wire. So that's the reason why I inserted a long crimpable hook in order to apply a parallel force in relation to the occlusal plane. Now, what's gonna happen if you hook up a power chain from the mini screw to the arch wire into this short crimpable hook? You are gonna have canting of occlusal plane. And I don't want to have canting of occlusal plane. So here you can see the lateral view of the biomechanics. A parallel force is the key in order to have the best correction of this asymmetrical malocclusion. Now, the amount of force is around 10 to 12 ounces, which corresponds to 280 grams to 340 grams. Wow, very good results after only 10 months of asymmetrical correction while using the IZC screw. Total treatment time was 19 months till here. Frontal view after 10 months of asymmetrical correction. Here you can see the unilateral correction of the IZC mini screws. And also here you can see the results after 20 months of total treatment. Now, let's gonna see the morph, which is good to showcase the changes. Here you can see the intercuspation phase. We are running a stainless steel braided arch wire, 19 by 25 arch wire. And here she is at the end of the treatment after 21 months of total treatment. Beautiful smile arc after the correction of her asymmetry. I don't know if you realized, but she had a surgery of her nose, which is now much better than before. Here you can see the frontal view before and after treatment. And also lateral views, a nice occlusion after 21 months of treatment. Her cephalomet superimposition, not much of a change, only minor dental alveolar changes. And you can see here, finally, her panorex before and after treatment. So in conclusion, asymmetrical malocclusion in an adult patient has always represented a challenge to orthodontists, especially class 2 subdivision malocclusion with maxillary implications. Mini screw placed in the IZC area allows more biomechanical versatility of orthodontic movement, since high screws prevent tooth roots from interfering in tooth displacement. And finally, IZC mini screws is considered a rather simple and more effective method in comparison to other type of skeletal anchorage method, such as mini plates. So thank you so much for your attention.
Hello everyone. At the onset, I would like to congratulate and thank the organizers of the 9th International Orthodontic Congress for inviting me as a guest speaker. I would also like to thank the editorial board and my readers at APOS Trends in Orthodontics for recognizing our work. Thank you. This is a video presentation of our article titled Modified Precision Lingual Bonding Technique, a stepwise approach with the torque angulation device and the bracket positioning device, published in APOS Trends in Orthodontics in 2017. I am Professor Dr. Vineet Veeti. My co-authors, Dr. Tina Paul, Dr. Lijil A.R., and Professor Dr. P.P. Bishwas are academic faculty at colleges affiliated to the Kerala University of Health Sciences, India. At the onset, I would like to make a disclaimer. Neither me, my co-authors, nor any of our family members have financial agreement or affiliations with any corporate organization offering financial support or grants for this presentation, nor do we have any financial interest in commercial products or services we have discussed in this presentation. As someone rightly pointed out, necessity is the mother of invention. Thus was the development of the lingual appliance. In 1980s, Dr. Kevin Thurs of California, USA, and Dr. Kinya Fujita of Japan, whose clientele mainly included renowned and affluent personalities, developed the lingual appliance to meet their needs. As in case of conventional labial appliance, the success of treatment depends on the appliance design, prescription, and the precise bracket positioning, in addition to the orthodontist's skill, training, and knowledge. The main challenge in lingual orthodontics compared to the labial technique are uneven and dissimilar lingual anatomy, variation in the tooth alignment, in addition to the complex biomechanics involved. Thus, the need for an accurate torque and angulation determination and bracket positioning technique was necessitated. Some of the commonly used techniques include the Selvia Giron's bracket positioning jig, Omco's Targ, Class, Filion's Best, Hyro system, the Top system, etc. But the real difference came with the introduction of the TAD in 2004 and its digital version, with the combination of bracket positioning device and the cast surveyor in 2006. As the theme of the virtual congress goes, broadening the vision in orthodontics, let's understand the stepwise procedure in custom bracket positioning and fabrication of the transfer tray for indirect bonding using the TAD BPD machine. Coming to the armamentarium, we have the torque angulation device, the bracket positioning device, the cast surveyor, the height measuring gauge, and the hand instruments, adhesives, and the lingual brackets. Coming to the procedure, it can be divided into 6 phases. The diagnostic phase, which includes case selection, history taking, examination, and treatment planning. The impression and the model preparation phase, the TAD phase, the BPD phase, the transfer tray preparation phase, and the clinical phase. The discussion of the first and the last phases are beyond the scope of this presentation. Coming to the impression and the model preparation phase. Accurate alginate or elastomeric impressions are made. These are poured with high density, high strength dental stone. Bases are made, trimmed accordingly. The long axis of each tooth is marked on the labial, occlusal, and the lingual surface. The midpoint of the clinical crowns are marked on the labial surface using the height measuring gauge. The horizontal orientation lines correspond. The midpoint are marked. Models are then sectioned to accomplish unhindered bonding. Models are then surveyed. Appropriate amount of torque, angulation, base thickness, and bracket height are determined and tabulated. Coming to the TAD phase, one has to calibrate the device using the orientation guide and set it to 0. Then the appropriate torque and angulation are set using the respective knobs. The models are then mounted on the surveyor and adjusted such that the center of the torque arc moment assay corresponds to the intersecting lines on the labial surface of the model. The model is then positioned and verified in the 3 dimensions of space, and adjustment knobs are locked. Coming to the BPD phase, the device is again calibrated to 0. Then the predetermined values are set using the adjustment knobs and locked. The brackets are fixed onto one of the bracket jaws. Primer and adhesive resins are applied on the bracket base. Position is verified on the model. Resin bases are contoured appropriately and cured. This process is repeated for all the brackets. The models are then separated from the surveyor base and is ready for the next phase. Coming to the custom transfer tray preparation, 1 mm Bioplast soft vacuum formed trays are preferred. It could be reinforced using 1 mm BioAcryl hard sheet over the Bioplast tray. One could also use Memosil transfer trays. Once these trays are prepared, the trays are separated, cleaned, sectioned, and labeled to facilitate easy bonding. Coming to the clinical phase, teeth to be bonded are cleaned and polished. Nola's isolation system was used to get a dry field and improve visibility. The bonding was done in segments. The desired teeth were etched, primed, adhesive applied, and cured. The trays were separated and preserved for any future rebonding. Coming to the conclusion, models and tray sectioning facilitated in unhindered bonding, both on the models as well as in the patient's mouth, especially in severe crowding and rotation cases. Thus, the need for model duplication and Kessling setup was completely eliminated. Easy bonding and rebonding was facilitated by the transparent flexible trays. Also, the bonding can be accomplished as a single tooth to a segment or in fact the whole arch. Thank you very much.
The road ahead is long and not easy, of course. This is not a moment of joy, but a moment of taking the responsibility and burdens to be the designated editor-in-chief for the APOS Trends in Orthodontics. To take the task of the road ahead, we have formed the new editorial teams, and we have the editor-in-chief. We have 5 associate editors, and we have around 20 assistant editors. The APOS Trends in Orthodontics had 3 associate editors, and now we have 5 associate editors from all over the world, including the Asian Pacific region, Oceania, North America, and Europe. Let me introduce myself. I'm Eric Gill, and I'm an associate professor in the Department of Craniofacial Orthodontics, Chang'e Memorial Hospital and Chang'e University, Taipei, Taiwan. And I was expert in craniofacial anomaly, surgical orthodontics, treatment of Class 3 patients, in bone physiology, in dissection osteogenesis, application of TACE, and treatment of facial symmetry and occlusal cant. Our new associate editor is Dr. Peter Ngan. Dr. Peter Ngan is the chairman in the Department of Orthodontics at the School of Dentistry, West Virginia University, and also he is an expert in Class 3 related treatment and clinical researches. Dr. Kijun Lee also is one of our new associate editor. He is the chairman in the Department of Orthodontics at Yonsei University, Seoul, South Korea, and he's an expert in TASE, in bone expander, biomechanics, and Class 2 related treatment and researches. Dr. Benedict Wilmers, he is a professor in the Department of Orthodontics at the University of Düsseldorf, and also he is an expert of TASE, bone expander related clinical treatment and researches. Dr. Thailand Charuparangkong, he is an instructor in the Faculty of Dentistry of the Mahidol University in Thailand, and he is expert of all kinds of feature-related clinical case reports and clinical researches. Dr. Narayan Gandikat, he is now an assistant professor in the Department of Orthodontics at the University of Sydney, and he is an expert in surgery first orthodontics. Also, he is an expert in cleanliness and palates, and also he is good at basic science research, systematic review, and meta-analysis. So the road ahead for the new teams was last night when I searched on the website to see how many journals in orthodontics. I found out the APOS Trend in Orthodontics is just a journal among many journals in orthodontics. And the question would be how the journal could stand out among the list. So our new team aim to keep the APOS Trend in orthodontic as an open access peer-reviewed journal committed to publishing high-quality articles in the field of orthodontics. And for the review process, we aim to keep having a highly rigorous, professional, and efficient peer review process that makes sure that the manuscripts are scientifically accurate, relevant, novel, and important. For the type of the manuscript, in addition to the current original article, feature case reports, and expert corner, we aim to increase the number of systematic review and meta-analysis. We aim to have more feature case report with STL file, 3D model viewer, which was recommended by Nikhilesh Vaid, our former chief editor, editor-in-chief, and also we would like to accept the paper with pilot study on innovations, such as have 5 to 10 cases of pilot studies, and also we would like to have the original article, feature case report in craniofacial anomaly, and the cleanliness palate as well. Since we don't have a journal related to the craniofacial anomaly and cleanliness palates from the Asian Pacific region. We also aim to establish the APOS Trend in Orthodontics key opinion leader blog or Facebook by an independent third-party host to further review and comment on certain published articles in each issue of the APOS Trend in Orthodontics. We also aim to have 6 issues per year. Currently, we have 4 issues per year for the journals, and the acceptance rate ranges from 35 to 45. We aim to keep the acceptance rate and increase to 6 issues per year when the manuscript and the journal font are both good enough to support have more issues per year. For the indexing, we aim to be indexed by the PubMed. Currently, the journal is registered with many abstract partners such as Google Scholar, National Science Library, etc. And recently, we are also indexed in the emergence sources citation index. So the road ahead is long and not easy. To achieve that, teamwork to make the road easy and accomplish the task to the end of the road. Thank you very much.